good afternoon from my side. As was said, my name is Jiří Kuchyňa. I am CEO of Aireen. Aireen is a producer of medical device which is based on the AI, and we are making diagnosis from the screen of retina of your eye. So by this we can see many symptoms, not on human health, but in healthcare sector itself. And that's what I would like to talk about. What is the current status? What is in front of us in the very near future, and how we can avoid the totally disaster in our healthcare system. We are having in our healthcare system really a ticking bomb. In the first part of the slide you can see, and it could be summarized by one sentence: the healthcare sector is currently now overloaded. But you can see what is in front of us in the near future. You can see that the prevalence is, maybe it's not so visible, of these selected 4 lifestyle diseases will be significantly growing, for example, by hypertension by 40% in comparison to the current status till 2030. So we are not talking about what will be here in next 50 years. We are talking what will be here in 5-6 years since today. So if the healthcare sector is currently overloaded and this is in front of us, something is wrong, and we have to find a way how to disrupt the system, the current processes which are there. And one of the ways which we can use for this is digitalization. This is a clear example of the diabetic patients. So currently in the world there is roughly 500 million patients with the diabetes. In 2040 there will be 783 million patients. So you can see the growth is 28%. Each and single diabetic patient should be at least once a year treated if he is having symptoms of diabetic retinopathy, which leads to the final blindness of such a person if it's not treated correctly. So once a year, every person should be treated. But the number of ophthalmologists who are doing it today is increasing in the same period just by 2%. So you can see here that the system is not able to handle so many customers. If we will look how it's running today in the system, patient is having some symptoms. In the better way, he is going to general practitioner, and the general practitioner is doing just one thing. Is collecting the symptoms, feeling, actual status of the patient, and better safe than sorry, is sending this patient to the specialist. Many of the patients are going to the specialist directly. The specialists we are talking to are saying in some selected areas that they are having up to 80% of healthy patients sent to them just for the check if they are healthy or not. Imagine, 80% of healthy patients are going to the specialists. It's clear, for example, all diabetic patients should be screened, but the diabetic retinopathy is only by 15 to 20% of the diabetic patients. So it's clear that 80% of them will be healthy. But all of them are currently going to the ophthalmologists. So at the end, it leads that the specialists who should take care about the really needed patients are taking care about healthy patients. When we are thinking how to do it, we think we should learn from someone. Someone is doing it better than the system is doing it currently now. So we know that if there is any mass incidents, or very well it's handled in the army, it's something which leads to prioritization of the patients. So there are systems how to prioritize the patients, which are having prior 1, prior 2, prior 3, and based on this, there is a selected treatment for such a patients. So we are thinking, why not to do it the same way? Why not to prioritize the patients, to identify the really needy patients which should go to the specialist? So first of all, we had to identify the point where the patients are most often. And we came to the conclusion that this is exactly the general practitioner. It's a place where all the patients are coming once a year, every second year, but it's the most often place where we can meet the patients. So why should we not do this selection by the general practitioners? We need a solution which will be cost-effective, which will be available, it's linked to the point of contact, and which will be accessible for the patients. Very important thing. For example, the screening from retina is fully painless, is comfortable for the patient, and many diagnoses could be done on one place. So a patient doesn't need to travel, spend the time, and so on. So when we are identifying this one, we are targeting to the final solution, which could help to the system. Patients still will go to the GPs. GP will still collect the current symptoms of the patients, feeling of the patients, and all the full anamnesis. But he will get one more additional information, which is the digital scan of retina, and based on the AI model, he will get the results of this scan, which will give him a clear answer if this patient should stay in his or her care, if this patient should go home because he is not ill, or if this patient should go to selected specialists. We spent a lot of time on this, thinking about if it's correct to have the concrete diagnosis. For example, by the neurologist, we are able, or we will be in the future able to have a diagnosis for Alzheimer's disease or Parkinson's disease. But at the end, this is not the crucial point. This will cost a lot of time for us, a lot of money, but what we need to achieve is that we will know that this patient we are talking about should go to the neurologist. And even the symptoms on the retina are very similar for both these diseases, so maybe we would have not 90% sensitivity, specificity, what is our target in all diseases, but maybe we will have just 80. I'm saying just, it's still quite a nice result. But we will spend a lot of time on this. For us, it's better to select this is patient who should go to the cardiologist. This is a patient who should go to the neurologist. This is a patient who should go, who is having the chronic kidney disease and should go to the specialist in this area. So that's the way how we see that the digitalization could help to the overloaded digital system, health system which we are currently having now, and that's the let's say effort which we are investing to bring this solution to the practice and to be accessible for as many patients as is possible. Currently, here is just the example of the diseases which we are doing in Aireen. So currently we are able to have diabetic retinopathy and age-related macular degeneration. The team is already working on the hypertensive retinopathy, and you can see many of these other illnesses, diseases on which we are working on, including, for example, a very popular longevity product, which is biological age of the patient. Here is the summarization of the benefits. So first benefit, we are in the healthcare. We should still have the patient on the first place. So first benefits are for the patient. Saving time, less stress. Imagine that you are by your GP and he will tell you, probably you could have some neurologic issue, I will send you there. You are in the stress for the next 3-4 months because you are waiting for the time by the doctor, and after 3-4 months you will get a negative result. So we are as well limited the stress of the patients when we can see that this patient is not ill. So time saving, less stress, and all the treatment is very comfortable for the patient. It is as well for GPs very useful things, because we are having recertification MDR2B. It means we are taking the risks. He is getting not the advice how to decide. He is getting from us as well the decision. So he could have much more accurate diagnosis. It's fast and based on some evidence. And as well, it's a huge benefit for the specialists where they are really having time for the needed patients. So that's the summarization of how Aireen could help in digitalization in healthcare and what we can bring to the system. Thank you.
Thank you.